Yes, boss. These guys are all golf. The drivers. I thought I'd seen one here. One day was sent by. They are going to the air.
Hello, good afternoon.
Good afternoon.
Okay.
Good afternoon.
Good.
Hey, I do
This
tell
is
you.
Justin.
So Justin, how are you?
I'm doing very fine, thank you.
Yeah, welcome.
I hope you people are very well.
Yeah, we're doing well. I'm good.
Okay. Nice meeting you online.
Hello, everyone.
Hello.
Yeah, can you hear me?
Yes, we can hear you loud and clear.
Yeah, we can hear you.
Yeah, we can hear you, Sarah.
Okay, if everyone is around, I guess we can start now. I don't see Dr. Atem. Okay, so let's start.
I am online. Can you hear me?
Thank you very much. I have seen you. Okay, so good afternoon, everyone. I welcome all of you for today's webinar, and I appreciate you very much for taking time to be with us here today. So before we go further, let me start by introducing myself to you. I am Dr. Sarah Zakaria, the Advocacy and Campaigns Officer for South Sudanese Women in Medicine. So before we go ahead, let's set our rules first. So if you are not asked to speak, I kindly ask you to keep yourself muted, as well as your cameras. And I ask all of you to switch on the camera when you are asked to speak, if that is okay with you and if your boundaries can allow. So our today's webinar is going to be about empowering the front lines, and it is the first part of our advocacy webinar series. It is going to be moderated by Dr. Adud Jarfes, but I'm just here to talk to you briefly about what Sswim is, and also to let you know more about our webinar series, and to introduce to you our moderator of today, Dr. Adud as well. So briefly about South Sudanese women in medicine, we are female South Sudanese female medical doctors, pharmacists, and dentists. Actually, South Sudanese Women in Medicine is a membership-based non-profit organization. It is dedicated to improving healthcare and health service provision in South Sudan through the engagement of South Sudanese female medical doctors, pharmacists, and dentists. If you want to know more about us, you can visit our Facebook page, and you can also get us in LinkedIn, and you can check our website, that is www.sswim.org. So this webinar advocacy series, it is a set of webinars that is aimed to ensure the community knows more about the two newly introduced vaccines, that is the PCV for pneumonia and the Rota vaccine for diarrhea. Those two vaccines were launched in May 27 for children under 5. So without going further, let me introduce to you our today's moderator, who's going to moderate for us today's webinar. That is Dr. Adud Jerfes. So Dr. Adud Jerfes Manuat Adiang is a health supply chain specialist with over 15 years of experience leading pharmaceutical, logistics, procurement, and healthcare delivery system across South Sudan. She holds a Bachelor of Pharmacy from University of Al Jazeera and a master's degree in health supply chain management from the University of Rwanda. Dr. Adud is currently pursuing a Master of Public Health at Cavendish University to deepen her expertise in health system management. Adud leads medical supply chain operations at Cordate, and she's overseeing procurement planning, distribution, logistics, and coordination with partners to ensure timely delivery of essential medicines to health facilities. Dr. Adud is the founder of the Girls Space Project. It is an initiative empowering adolescent girls through health education and mentorship. Adud serves as deputy chairperson of the South Sudan Doctors Union. She is also a former Secretary General of the Women Support Network Organization. That is a member of South Sudanese, and she is a member of South Sudanese Women in Medicine. She is an alumni of the Women Lift Health Global Leadership Program. Adud is committed in advancing South Sudan's health system through transparency, efficiency, and sustainable medical supply management. So, Dr. Adud, you are welcome for today's webinar. And over to you, moderating this webinar. Thank you very much.
Yeah, thank you, Dr. Sarah, for the nice introduction. As she has mentioned, today I will be the moderator for these sessions. Good evening to all participants joining us from everywhere in South Sudan. As she has mentioned, my name is Adud Jerfes, and I am honored to serve as the moderator today to this important session about immunizations under the theme Champions of Health, Equipping and Empowering South Sudan Health Workforce to robust immunizations program. To my knowledge, this is the fourth and the final webinar series following the successful launching of the PCV rotavirus vaccine on the May 27 this year. Our focus today is on those people who work at the heart of the immunizations program, our doctors, Boma health workers, vaccinators, pharmacists, and public health leaders. We are here, all of us, to listen, to learn, and to share experience, strategies, practical, to build a stronger, more confident health workforce for immunizations. As all of us are aware, this session is hosted by South Sudan Women in Medicines. And I don't want to talk more. Let us just begin with short introductions of our speakers. We have today 4 speakers. And then after the introductions, we will go direct to our questions. And then from there, we will have chance for questions and answer. And also you can put your question in the chats. We will read it, all of us, and we will direct it to the right speakers for today. So today, we are honored to welcome our first speaker, Nathan Riab. Is a distinguished public health leader serving as the Director General of the Primary Health Care in Ministry of Health of Republic of South Sudan, with a career rooted in advancing equitable healthcare access. Dr. Tim has played a vital role in shaping national health strategies aimed at improving outcome for undeserved populations, for underserved populations. He has been instrumental in launching the national Reach Every County REC immunization guidelines, a transformative initiatives designed to increase vaccinations coverage from 80% to 95% nationwide. Under his leadership, South Sudan South Sudan has developed a comprehensive five-year health plan supported by GAVA, the Vaccine Alliance, to strengthen health care delivery and resilience. Dr. Tim is recognized for his programmatic approach to addressing public health challenges, particularly in reaching children in remote areas and closing gap in routine immunization. His work reflects a deep commitment to the immunizations agenda 2030, the Sustainable Development Goals, and the broader visions of universal health coverage. Through his strategic foresight and collaborative spirit, Dr. Atim continues to be a divine force in South Sudan journey towards a healthier and more inclusive future. Our second speaker is Dr. Justin Tangun. And Dr. Justin Bruno Tangun is a leading South Sudanese pediatrician, researcher, and health system expert with over 15 years of experience in clinical care, public health, and academic medicine. He served as the executive director at the Sabah Children's Hospital, the country's only dedicated pediatrician referral center, and as assistant professor of pediatric at the University of Juba, where he has been instrumental in launching the Master of Medicines in Pediatrics and Child Health program. Dr. Tangun holds an MBC HB from Barara University and an MMed in Pediatrics from Makerere University, a PhD from the University of Bergen. He has published widely on child health with research spanning malaria, breastfeeding, neonatal cares, and health facilities utilizations. As chair of the National Polio Education Committee and consultant on vaccines program, he plays a key role in strengthening South Sudan immunizations effort. Beyond clinical practice, he champions healthcare infrastructures and policy reform, and currently leads the Health and Social Science Research Institute of South Sudan. Dr. Tangun, his work reflects a lifelong commitment to improving child health and building sustainable health system in fragile contents. Our third guest is Dr. Christine Lino. Christine Lino is a dedicated supply chain officer with 3 years of professional experience in the health sector. Currently, she's managing supply chain operations at the Central Medical Store, CMS, under the National Ministry of Health in South Sudan. In her role, she has effectively optimized logistics and ensured the timely delivery of essential health products. She is playing a crucial role part in improving her country healthcare system Before her work at Central Medical Store, Christina gained a valuable experience both in hospital and community pharmacy setting, where she honed her skills in pharmaceutical management and patient care. Her proven ability to streamline operations and enhance efficiency and root it in her strategic planning, data analysis, and innovative problem-solving capacity. In addition to that, to her operational responsibility, Christina is an active member of the Pharmaceutical Society of South Sudan, PSS, as a newly appointed lead of subcommittees on pharmacy practice and ethics. She is committed to advancing and advocate for the pharmacy professionals in South Sudan, ensuring that ethical practice and high standards are upheld within the field. Christine also is a graduate of University of Medical College in Addis Ababa, Ethiopia, where she earned her Bachelor of Pharmacy degree in 2020. Additionally, she holds a bachelor degree in business administration from the New Generation University College. Our last panelist is Ms. Joyce Coron. She's a BHI consultant at the National Ministry of Health. So welcome all of you on board for our today's sessions. So without wasting more time, let us just start with our first questions. We are going to start with Honorable Director General, Dr. Atim. Dr. Atim, could you please give us an overview of the current staffing level of vaccinators across South Sudan and share what steps are being taken to address any gaps, especially during the vaccination campaign? Dr. Atim.
Yeah. Thank you, Dr. Adut, for the opportunity. First of all, I want to highlight that there is a shortage of human resource across the board for the in all the discipline, and immunization is not an exception. Also, I want to share with you that in South Sudan, immunization is not given by the same cadre like that has happened in our neighboring countries, whereby mostly it is nurses, clinical officers, and maybe doctors who would administer the immunization. In our setup, we have forced to create another cadre we call vaccinator. They are trained in a short training using the IIP module for them to be able to bridge the gap of the human resource. At national level, we don't actually do the service delivery. We are mainly concerned with policies, and the policy on the immunization health workforce is that we need a minimum of 2 vaccinators per health facility to be able to meet the needs of vaccination. Now, most of the facilities meet this minimum standard. In some places, you will only find that there is only 1 trained vaccinator of vaccination. During the COVID-19 outbreak, we had to do a crash training of about 1,500 vaccinators to bridge the shortage in the vaccination workforce. The other thing with the vaccinators is that there is a high rate of attrition. They move on. And so we will have to keep on replacing them. So those are basically the challenges of the human workforce in the vaccination space. The figures, I cannot give you figures because those people are not employed under us. They're usually employed at the subnational level, and the figures keep changing. But the guideline is that 2 vaccinators per facility. Thank you.
Thank you, Dr. Atim. Now we are going to our second, Dr. Tangun. Dr. Tangun, from your clinical and leadership experience, what challenges have you observed among trained vaccinators regarding the workload and the knowledge of the new vaccine, especially now after introducing the new vaccine? What is the challenges that you have observed? Yes, Doctor, can you unmute yourself, please?
Yeah, thank you very much for this opportunity to share the experience we have. The challenges that are already well elaborated by the DG is regarding workload, is increased patient volume. As you have learned, these vaccinators, most of them are not really nurses, clinical officers, or they are just trained vaccinators. By virtue of their training, then they become vaccinators. So, and most often you find 1 or 2 in a facility. So there's increased volume of work. That is one of the challenge. And already another challenge that has been clearly marked out by the DG is limited staffing. The staffing are few. Sometimes you can find 1 or 2, or sometimes they were done rotating within that. The other challenge that is there is really limited is time constraint. Administering a new vaccine require a lot, especially the new vaccine that has just come, the pneumococcal, often require more time per patient due to extra steps like consent and explaining the possible side effect. So this also burn out this team, because by the time you see many patients, you're burn out. So there are basically 4 challenges. One is increased patient volume, limited staffing that constrain these people, and then time constraint because they take long in order to administer this new vaccine, burnout because of heavy work that is involved, and that is as far as workload is concerned. Regarding knowledge and training, insufficient training on new vaccine. Often training is brief. The training given to these people, it is brief, and it covers many areas like dosage, constraint, handling, and side effect. And remember, these vaccinators are not medical doctors or medical practitioners. They're just people who are trained on how to administer these vaccines. So insufficient training is one thing, because they are trained for a very short time, and that affects the work. And of course, you can't be able to get them enough knowledge in order to do the needful, but they are given just the basics for them to do the needful. So they lack a good knowledge on that. Rapid changing guidelines. Now, as soon as these 2 vaccines came on board, we have to adjust the guideline quickly, and so that they begin to do the work. But they were used to the routine that they were doing. And now this rapid changing of guideline also influenced negatively these vaccinators, since most of them are low cadres and of low educational background also. Language and literacy barrier. This could be another one. Because in other areas, you'll find that these vaccinators neither read English very well, neither read Arabic very well. So in some setting, training materials may not be available in local languages or at appropriate literacy level. So it affects them. And then lack of practical hand-on training. Most of these vaccinators, as I said, they're trained for very short time. And so they have never had enough sufficient time to have hand-ons. So basically, the challenges as far as knowledge is concerned is insufficient knowledge because of short training, rapid changing guideline also act as a challenge, language and literacy barrier act as a barrier, and then lack of practical hand-on training because that is given for very short time and that affects them. The other challenges that they face, the vaccinators face, is the public interaction challenges to do with the public. Public hesitancy, vaccine hesitancy questions. Most of the parent vaccinators may not feel equipped to address patient concern or parent concern or misconception about new vaccine. So they get challenges in explaining this side effect. And so that is a big burden for them again. The other thing is documentation burden. Most of these new vaccines often require additional data reporting, which adds to the vaccinator's clerical workload and reduces time for the patient care. So for the public, there are only two challenges that come from that area: vaccine hesitancy questions that some vaccinators find it difficult to answer, documentation is a burden because that is required. So those are the challenges that fall in these three areas. One is workload, and then the other one is knowledge, and then the third one is public interaction challenges. Thank you.
Thank you, Dr. Justin, for listing out for us the challenges that you have been facing as a pediatricians and as someone that is working and interacting with the vaccinators. So it's a quite long list of challenges, and maybe all of us can try to think the way how we are going to navigate and to see how we can come with actions points and solutions to these challenges. So let us go to another speaker. Let us go to Ms. Joyce. Ms. Joyce, from your work supporting boomer health workers, what will you say are the primary challenges that face in raising awareness about the vaccine within their communities? Ms. Joyce, are you around? Okay, maybe we can just move ahead and then we'll come back to her later. Dr. Christine, in your view, can you just tell us what is the strategies that can we employ to ensure that all healthcare workers, not just the frontline vaccinators, are kept up to date with the newly introduced vaccines? Please, Christine, can you, put your video?
Thank you, Doctor. And thank you
Yes.
for this amazing question. Before we go in deeply, like what healthcare workers, they are part of the community. And they get vaccinated, their children also get vaccinated. You don't always have to wait for the Ministry of Health to keep you updated. There are certain things that you can do, personal effort, to keep yourself updated as a healthcare provider. The number one thing, you can consult healthcare professionals who are involved with vaccines. So not all information is available for everyone. So you can consult them about which vaccine is available now, the new vaccine. You can ask them about the safety profile of the vaccine, the benefits, the risk, and all this information you can get from your colleagues and so on. And also you can utilize the official health resources. And when I say official health resources, I'm talking about the website, the internet now. Everything is available at the tip of the finger. so everyone can access, but not all information out there is trusted. Not all information there is valid. So we should be aware which site we're going to access. For example, we can go on the WHO website, the CDC's website. They have up-to-date information about the vaccine, the current vaccine, and the recommendation that they can give us. And also there is a professional association. For example, we have the Doctors Union. Doctors Union is it includes pharmacists, doctors, dentists, and all the health care professionals. In that platform, usually they share information about the newly introduced vaccine, like the PCV and rotavirus vaccine. Me myself, I got the information even from that platform. So it's one way that you can get the information, and also engaging with community-based initiatives. As a part of the community, you can work as a vaccine champions, or you can be part of the community and you approach the community leaders. There's always a community education programs that is being done in all over Juba. So it's one way that you also can keep yourself updated as a healthcare provider. And when you have all this information, healthcare provider, you can use this information to stay informed about vaccine hesitancy, because hesitation about vaccine is a real thing, and most people, they're afraid to communicate it. So if you know where to get the information, and now you know them, you can also update yourself on how to address the issue of vaccine hesitancy, and also how you can solve them. Because as a pharmacist, a person working in a community pharmacist, I always get many people come to me with a complaint. They're complaining about certain vaccine, or they're fearing certain vaccine. So I have to take my time to research by myself, to keep myself updated every day. It's a continuous process. So we should never get tired of updating ourselves about vaccine. And also for ourselves, we need to evaluate vaccination needs regularly. So can always check, what vaccine do I need to take? What vaccine my child need to take? So by this, we can be updated about all the vaccines that are available. Thank you.
Yeah, thank you, Dr. Christine. Can I just follow you with another questions? In your reason, you have mentioned that platforms, that means you need internet. You need internet to have access to these platforms. What is what will happen for those who are not, we are in South Sudan, accessing internet it's a luxury. Not each and every doctor or a health worker can have access to the internet. What is you are saying that? How can they get the access to the informations?
They can go to a nearby health facility, because usually there's a vaccine department or immunization program office in each health facility. If they go there, they will get the information that they need. And sometimes even, those health workers, the Boma health workers, they move in different areas. When you meet them, they come and knock your door. So it's also an opportunity for you to ask about this vaccine. And then furthermore, you can ask your colleagues, and you can go and read about this vaccine. It's just a process that, you have to try to find a way. So the government is trying their best to make it available for everyone. Those who are not in the social media, they can meet those people in person, the hospital, or even in the place that they live in the community.
Okay, thank you. Thank you, Dr. Christine. Let us go back to Ms. Joyce Koran. I can see her, she's around. Ms. Joyce, let me just repeat your questions again. I said from your work experience and supporting Boma health workers, what will you say are the primary challenges they face in raising awareness about vaccine within their communities?
Thank you, Dr. Dutch and the team. I hope you're getting me well now.
Yes, I'm getting you well.
Yes, sorry, I was in another meeting. That is why I was just moving out. Thank you very much for the opportunity. And it's really a pleasure for me to be in this forum. Just let me maybe say a few things before I start with the challenges on BHI, so that maybe you have also a background on BHI. BHI is the vision of the late Dr. John Garang. You will find all this in all the community health strategies, especially the Boma Health Initiative, about this vision, taking towns to villages. It was launched in 2017 and rolled out in 2018. BHI is a formal structure of the health system to close the gap between the health facilities and the communities. We know that most of our communities live beyond 5 kilometers, so access to health facility becomes a problem. That is why Boma Health Initiative should cover the gap. And then secondly is the entry point for community level health interventions. All the community health activities have to go through Boma Health Initiative. Thirdly, is expected to deliver an integrated package of health promotion, disease prevention, and selected treatment services. That is for malaria, pneumonia, and diarrhea. So these are the three things. When it comes to promotion, this is mostly awareness on immunization, identification for defaulters, referral for vaccination, and feedback mechanism. This is just about Boma Health Initiative. When it comes to challenges, actually, Boma health workers in South Sudan, they face combination of structural, social, and logistical challenges in creating vaccine awareness. One, knowledge, they lack knowledge on new vaccines, like now the Rota vaccine and the PCV. The Boma health workers are not aware of these vaccines. Low literacy level and lack of communication tools. Literacy level, you find some counties, they are illiterate completely, like 90 or 95% they are illiterate. And then number 3 is misinformation, rumors, and deep-seated cultural beliefs. And you know, the Boma health workers, they are in the community, they are part of the community. So if they lack knowledge, then it becomes difficult for them to really raise the awareness of these community members and to actually change the beliefs and the attitudes, so that the vaccine hesitancy, which is a stumbling block, will be actually removed. Limited supportive supervision and refresher trainings. Most of them receive initial training. Their refresher trainings are not there, whereby if their refresher trainings, they can actually be given information or knowledge about the new vaccines so that they also gain the new knowledge. And then geographical inaccessibility and poor transportation. This hinders outreaches, like outreaches for immunization, outreaches even for awareness campaigns, or also displaced populations. Sometimes this geographical inaccessibility affects the Boma health workers. So the support needed is a provision of contextualized IC materials, flip charts, and audio aids to local dialects, especially like some locations I went to, like in the Capoeiras. The Boma health workers, for them to understand well, they have given names even to the 3 diseases they are treating, like the pneumonia. They have a name for it, it's called yokitoi. Yokitoi, so now when you talk to them, how do you treat yokitoi? They will start explaining to you. And they will actually tell a lot of that. So this is what we need. And then another support is actually regular predictable remuneration and recognition schemes to boost the motivation. Like these Boma health workers, they continue doing their work, but what next? Even they have to be involved, like in these campaigns, if they can be involved. They are trained or they are given a refresher, then they go and provide awareness. Like in the COVID-19, some of them even went to the extent of talking to the community members. Then the community say, no, the distance for the vaccination site is long. Let us wait here, bring the vaccinators here. So they have also to come to the vaccination site, pick the vaccinators, and they go and vaccinate people from where they decided to collect. So another is continuous capacity building, not just an entry, but through periodic or modular refresher trainings. Modular refresher trainings, like in the BHI training, especially that is phase 1, which is child health. Yes, immunization is there. And actually the immunization, only the traditional routine vaccines were there. But now with the introduction of the new vaccines, they are not part of the training. That means they need actually to have this modular training, and even through the implementation, we learn a lesson that some of the things are missing, because in the immunization component for BHI, it was only identification of defaulters and referral. But later on, we realized 0 dose identification and tracking is missing. and feedback mechanism. If the child has been referred for vaccination to the facility, has the child really been taken to the facility? Have the child got vaccinated? Is there anything to show that the child got that? And will the child, the defaulter really be identified from the facility? Will the vaccinator identify the defaulter from the facility through the dropout cards? Will they identify that so that there is a feedback mechanism, we don't miss any child in between? And then lastly is actually investment in community mobilization logistics, including transport and mobile communication devices. Most of them, they lack megaphones, others lack bicycles. So now they have to actually walk around and just use the mobilization through direct communication, like just talking. So these are a few of the support which is I think will really support the Mama Health Initiative. Thank you.
Yeah, thank you, Joyce, for the numbers of challenges that you have mentioned, and also how we can support the Boma Health workers with small, maybe motivations that can help them, support them to keep going and moving and deliver the work to the end destinations. Let us continue with our questions. Dr. Tangun, as a pediatrician, working closely with children and caregiver, what are the most common misconceptions or areas of low awareness about PCV, rotavirus vaccines that you have encountered among the healthcare workers and parents? Dr. Justin? Are we with us, or we can? Okay. Let me just go directly to the Honorable Director General, and then we come back to Dr. Justin later. Okay. So, Director General, can you share with us the ministry current plan for expanding the health workforce and ensuring the equitable deployment of vaccinators, particularly when there are a campaign for the vaccines the way we have now?
Yeah, well, the gaps, there are big gaps in healthcare coverage in this country. The current health facilities we have are the one that we inherited from Sudan, and they were mainly along the border areas and areas that were away from the war of liberation. And so after the independence, we find ourselves that most of the country do not have health facilities, and even the available ones are dilapidated, they are understaffed, they are under-equipped, and even supplies are not adequate. Those are always the issues that come up. So to improve the coverage, it needs an investment. The country needs to invest resources to improve the existing facilities and to build additional one. Of late, the politician resorted to upgrading some facilities. They'll just go and announce that this facility from today it is upgraded to the next level. And that upgrade will not materialize, because to upgrade a facility, you need a budget. If you are to build additional wards, or if you are to bring additional staff, those ones, they need funding. And the budgets we have been having for the previous years is they did not include a capital budget, which is the one that is meant for building and equipping facilities. Most of the budgets, they only provided the salaries and maybe some bit of operational cost, but nothing beyond that. Also, the human resource is an area that needs work, because you need to train many more healthcare workers at all level, and also not only training them. After you train them, you need to retain them, and the retention means they should be paid attractive packages. They should be provided accommodation. Like in the past, health facilities are built with accommodation next to the facility, such that the healthcare worker will be available 24/7. But that is not the case. Also, transportation, both for referral of cases, we need to invest on means to be able to refer cases from one level to another. At the lower level, community level, we have heard from the contributors that the Buma health workers need a lot of work on them. They need training, the basic training, plus they need refresher training to keep updating their knowledge as medicine and the way of doing things evolve. That evolution need to be communicated to them through refresher training. And also those trainings need resources to whether you do it at the periphery or you bring them centrally for training, it also needs resources. So I'll leave it there for the other colleague to add to it. Thank you.
Yeah, thank you, Honorable Atim. So what I can understand from your statement, that is the major and the most concern is about the financial resources. The gap, it is in the financial resources. We don't have enough financial resources. That's why we have gap in human resources. We do have gap in training to retain the staff and accommodation and all other things. So maybe also we can brainstorm and see how we can navigate also around this problem, and how we can come all together and try to see how can we solve this problem of the resources by the end of this session. So as we are still, Dr. Tangun, are you back? Dr. Justin?
Yes, I'm back, yeah.
Okay. So I repeat the question, or you have...
Can you kindly repeat the question?
Okay, so my question was like, as a pediatrician, so working closely with children and a caregiver, what are the most common misconceptions or areas of low awareness about the PCV and retrovirus vaccines that you have encountered among the health workers, workers and the parents?
Thank you so much. Thank you so much. Among health workers, the misconceptions include thinking that this vaccine is only for pneumonia, and let alone they have forgotten that pneumococcal can cause severe pneumonia, can cause meningitis, and can cause bacteremia or sepsis. So that misconception that is for pneumonia alone is causing problem, because they don't explain very well to the parent what the importance of this vaccine is. Number two misconception is that there's low awareness about catch-up schedule. We know that this vaccine is given at the age of 6 months, 10, and 14. But then, if a child comes after 1 year, there's also confusion of how many doses to give. But there's a clear path on what to do if the child comes late, if it's not given at birth, for instance. And then the third misconception is about uncertainty about co-administration. You know, these vaccines is given IM and is given in conjunction with other vaccines like diphtheria, tetanus, and pertussis, according to the guideline. So some health workers get confused. They will think this is too much to be given to this one child. So that uncertainty also creates doubts in some of these health workers, and then similarly it will trigger doubts in the parent. The fourth is confusion over vaccine brand. You know, there's PCV10 versus PCV13. There's some lack of clarity and interchangeability between the serotypes, because 13 and 10, these are just the serotypes that this vaccine cover. So some of these health workers, doctors and the like, get confused about this. And so these are misconceptions which are four in health workers. Parents do also have misconception about pneumococcal vaccine. Some may assume that their child don't need vaccine because the child is well-fed, well-nourished, especially those well-to-do parents. They said, no, my child is okay. I'm living in a clean environment. We don't need it. So that is the one that is big, especially for some parents. Number two is about fear of adverse effect. They feel this vaccine might cause problem in their children, and especially because it's IM, when it's given, there's always pain associated and the child cry so much. So the mothers, sometimes the parent, think this is a very serious problem. Also, the other misconception is about overload of the immune system, because this vaccine is given with other vaccines together at the same time, some in different routes though, but they say, no, these are too much. One child cannot get this vaccine. Why don't I give one today and come tomorrow for another one? So this fear of adverse effect and overload also confuses the parent and causes misconception. Regarding rotavirus vaccine, similar stories also happen in health workers. Uncertainty about strict age limits. Some thought maybe it could be an open thing. Many are aware that vaccine must be started before 15 weeks and must be completed by 8 months. So some of them are not aware about this, and that brings misconception and doubts on how to give this vaccine. Misconception also among the health workers is that some assume that if there is improved sanitation, this doesn't need this vaccine. And that is a very bad misconception. That is not good, because it doesn't mean only if your child lives in a clean environment, and doesn't mean you need not to get this vaccine. This vaccine is important and it must be given. Confusion about vomiting about this child. Some wonders, it is unclear whether vomiting right after oral administration affects efficacy. Vomiting doesn't, because once the vaccine gets into the mouth, the effect has started immediately. So, because some might have reached down to the abdomen already. So there's also that misconception in the health workers. Among parents, there's misunderstanding about disease severity. Some think diarrhea is just a common issue, so it doesn't need vaccine. And so some of them ignore it because of that. And there's also this misconception in parents and both health workers that this vaccine can cause intestinal obstruction, which we call it intussusception. But these cases are very rare. So because sometimes they have been told elsewhere by other parents that this can affect children this way, they tend to believe those people who tell them in the area other than the health workers. So, but those cases of intestinal obstruction are very, very rare. The other one is for parents is confusion due to oral dose. Some parents misconception think that any oral vaccine, it is not a very strong vaccine. They believe in the injection. So they thought efficacy of this vaccine is not strong because it is not injectable. So in brief, those are the misconceptions among parents and among health workers. Thank you very much.
Thank you, Dr. Justin, for listing out to us all the challenges on the misconceptions about the vaccines in workforce and then in parents. So a following questions, now you know all these challenges, you know all these informations. What have you, as a director of Asaba Hospital, what have you done to change these informations, or how, I don't know how to put it, but what do you actually did, what effort did you put on ground to try to remove a little bit of these misinformations, either from the health worker or from the parent?
Thank you so much. The effort we've put in order to clear this misconception is basically educational strategies. One strategy was to emphasize prevention of sepsis and meningitis, because this pneumococcal vaccine does. And so we do this through trainings, morning meetings, and awareness to these doctors and the clinic, and even the medical students that are coming up and about to finish. That is what we did. The other thing we did was to provide clear job aids and refresher training for these youngsters. Yeah. And then the other thing is also we avail to them WHO and national clinical guideline as a reference so that they can be able to use and they don't get confused. And to the parent, we share a real case scenario of people who got this vaccine and they fared very well, and they have not come to the hospital for a very long time with this condition of pneumonia, diarrhea, and other cases, because we have experience from other countries where some of us have been practicing, and we tell them this real case scenario and explain the universal risk of what may happen to the parent. We also explain that the risk of dehydration and hospital stay. For example, parents think diarrhea is just a normal thing. And then we tell them, imagine your child gets sick and gets severe dehydration. This child may easily die. And then the length of the hospital stay you can stay in the hospital for many days and even weeks, just managing diarrhea. If you are vaccinated, this will all be avoided. And we also tell them real case scenario about that. To the parent also, we made clarity on how oral vaccines are effective. And we tell them mostly about gut immunity. We educate the parent and we educate the health workers about gut immunity. So these are the few strategies, educational strategies that we have laid forward, and it is workable. And we have seen the effect. Thank you so much.
Thank you, Dr. Jackson, for your efforts and your continuous supporting our patients, our pediatrics ill patients in Sabah teaching hospitals. Let me move to Dr. Christine. Dr. Christine, can you tell us what communication strategies do you find most effective in raising vaccines awareness among health care workers themselves, especially beyond initial training?
Thank you, Doctor. As mentioned by Dr. Justin, he mentioned very great insights about what is going on Asaba Hospital. And actually it happened not only in Asaba Hospital, in all over Juba. The misconception, it comes from the unclear communication to the healthcare workers and also to their community. One way we can have an effective communication is by education, as mentioned. Education, continuous professional development. I know we are on budget, as mentioned earlier, we're having financial constraint. So by having small, it doesn't have to be something big, continuous professional development, we can mention something to those people, or even during supportive supervision, we can talk a little bit about this vaccine, the importance of this vaccine, and how we can address some misconception about the vaccine itself. So the healthcare providers, when they have the right information, to help them to address them rightly to the parents who are having those misconceptions. The second thing is improving access to information. I see that the South Sudan women in medicine have done a lot of things to make it accessible for everyone to know about the rotavirus vaccine and the PCV. I saw billboards that are there. The billboards will give you information about that, information about the vaccine. They can also add social media and the radio talk show and also TV talk shows. During the radio talk show, they can involve the drama. I remember during COVID-19, there was a small dramas about, people are talking about, like the one for Matutufu Buza. You have to, these scenarios, it will connect to me as a healthcare provider. I will know how I can respond. And the community, they will know how they can respond as well to me. So having that access to information, it will help them to know exactly what is going on and to communicate to each other very well. The third thing is that the campaigns, we can make campaigns. Those campaigns can bring vaccine champions to be there, the community leaders to be there, the health professional who are specialized in vaccine to be there, so they can raise awareness about vaccine communication, clear channel of communication between the healthcare workers, the Ministry of Health, and also with the parents and the patients. Another thing that we can do is to address the myth that is available in all over the country. There's myths about vaccine. Some people will say, if you take this vaccine, it might affect you in the future. Maybe you will not be able to give birth in the future. Maybe it will affect specific things about the baby. For example, one patient came to me and said, this vaccine will increase water in the brain of the child. I asked him, who told you this information? It's the myth that is circulating. And I know Dr. Justin, he has a lot of experience because most mothers, they come there and, they have misconception about it. So busting those myths, it will clear that misconception. It will make us all come together in one table to know exactly the importance of vaccine, and as a healthcare provider, how I can deliver the messages that I have to the patient and to the people that ask me. I think that's what I have to say. If someone can add more, that would be fine as well.
Okay, thank you, Dr. Christine. That was really a very good insight. And yeah, we are moving to the next, Miss Joyce. I hope you are around. Okay, the question is, how can the training and the supervisions of women health workers be improved to enhance their effectiveness as trusted frontline vaccines champions?
Thank you, Dr. Adut. Let me say improving effective Boma health workers requires a structured, layered capacity building approach. One is actually to have a standardized national training curriculum on immunization within the BHI framework. As I said earlier, we need to actually include those new learnings at the community level regarding immunization. Two, there is need, of course, also this request resources, but still it's good to bring it up, like roll out a digital training modules and job aids, which can be used both during initial training and as refresher contents as well. This one also will help, like for the illiterate Boma health workers, sometimes if the photos or the pictures are just put there for this this type of antigen, this is where the vaccination, which part of the body is taking and the age and all that, then it can easily be used. Establish supportive supervision, cascading it with trained supervisors, state and county immunization focal persons, conduct a regular hands-on mentorship. This one, currently, most of the Boma health focal persons at the state and the counties, they are immunization officers or immunization communication officers, which is really a very good connection because they now oversee immunization and Boma health as well. Then thirdly, is actually introduce peer learning models. Peer learning models like the monthly meetings or the quarterly review meetings where Boma health workers from the nearby Boma, maybe 2 or 3, come to the other Boma, and they actually discuss based on the review session. If they are reviewing about immunization, for example, the folder tracking, then others will actually share the challenges, and this happened also in some counties. We visited, like they share also a lot of experience from different Bomas. Then supervision should also shift from fault finding to problem solving and empowerment. Most of the supervision done, you see someone who say, you see the people who came here, they were actually criticizing instead of supporting them actually to solve the problem together. They may even find solutions for the problems. And then that means they are already empowered and supported. User-friendly checklists that integrate immunization performance indicators. If few things will be put there in the checklist, like, okay, I have referred maybe 10 zero-dose children. I have referred 5 defaulters, which will be in the checklist during the time of supervision. That one actually will help a lot during the supervision. This is just what I want to say, a few things about the supervision.
Thank you very much, Ms. Joyce. This is really very important and useful information you have shared with us. We can put them in actions, and I believe by the end of the day, we will have a very effective and more informative learners to do the vaccines. So as we are continuing, let me go to Honorable Dr. Atim, the Director General. Can you tell us what is the ministry doing to improve the remunerations of Boma health workers and streamline their database to ensure their continued motivations and effectiveness in supporting the vaccine programs?
Yeah, the ministry is doing a lot to support the subnational level, because the Boma do exist at the subnational level, and our role is to support them, make the guidelines, the training material, and also advocate for more resources from the partners and donors, such that they are supported. As of now, we were able to mobilize the resources for most of the BHWs to be given a top up of about $50 US per Boma health worker per month, and also they are to be in the government payroll at a starting grade. It was 17, but now it has been upgraded to grade 14. And then we also sending teams from the national level and also state level to go down and to supervise and to ensure that the Boma health workers are doing the right thing. Also, tools are being printed and they are being sent to them such that they are able to report. And the data is very important because it will help with the fine-tuning of the support that is given to them. So that is, I think, Madam Joyce Kuran could add more to this to complete the picture. Joyce Kuran, can you come in?
Yes, thank you, Dr. Tem. You have really said a lot, but just let me pick from the incentives. Yes, the Boma health workers, these are salaried government staff, but the incentives is the one keeping them moving. And as Dr. Tem have said, based on the experience during the COVID-19, it proved that Boma health workers have done a lot really to raise the awareness and actually mobilize people for vaccination and many other activities which they have been doing. And through that advocacy, it has resulted to increment of the incentives from $25 to $50. And on top of that, also other donors have seen, because there is the National Ministry of Health have done gap analysis of Boma health workers to see which counties still need more Boma health workers. And actually, Global Fund through UNDP have actually also added some Boma health workers on the existing Boma health workers so that we have actually a bigger coverage. This all results from the remuneration and the motivation and actually the performance base. So I think there is still a lot to be done, but Boma health workers, they're already doing the work. We'll just continue to support them and move forward. Thank you.
Yeah, thank you very much, Madam Joyce. Actually, this is a great milestone that for the ministry to manage to increase the incentive, actually to add the Boma health workers to the incentive list and to be getting like $50 monthly. This is actually a great milestone, and congratulations for that. Yeah, as we are continuing with our questions, Dr. Tangun, can you please tell me how can we better equip and empower medical doctors, pharmacists, to be more effective advocating for the routine immunizations within their practice and in their communities?
Thank you so much. I will give you a structural approach, although there may be many, but maybe you bear with us. First of all, there's a need, one, to strengthen immunization knowledge and confidence, to provide evidence base for these health workers, both doctors, technicians, pharmacists, and other health workers. And this provide continuous evidence-based education, and that is the only way we can do that. And then ongoing practical training to clear the myths and use of local data is also important. The other focus area will be communication. Key action, we need to build soft skills, role play, and storytelling skills. The other one, we need to also, another focus area that we need to focus as health workers and pharmacists and all the others is leadership. To elevate voices, to take control of what is going and involve all those in planning. Vaccines practices shouldn't be left to vaccinators only, but all of us will get involved so that we can lead us in this important task. Support tools is another area that we need to focus on, and so that this also provide toolkits, peer platform, and recognition so that people can collaborate and work together. And collaborations, this will foster team-based advocacy across all the professionals. Those are areas that need to be focused on. And then finally, we need to focus on to address the structural and system barriers. For instance, ensure vaccine availability, provide simple reporting system, advocate for policies that allow more providers to administer vaccine legally and safely. So these are the areas that we need to focus on, and that can improve what we are doing in our work, being it empowering doctors, pharmacists, and others. So those are the areas that we need to focus on and take clear action as I've outlined. Thank you.
Okay, thank you, Dr. Justin. Let us move ahead. Dr. Christine.
Yes, Doctor, are you there?
Yes, I am here. Are you getting me?
Yes, I can hear you now. I hope you got what I was saying.
Yes, I did. Thank you very much. Dr. Christine, can you tell us how can we create targeted culturally approach communications materials that address vaccine concerns among both health workers and the wider public?
Yeah, of course. Culturally sensitive communication about vaccine is really important in order for us to address the diverse beliefs and also to build trust between us and the public. So before we do that, we have to put in mind that we are a very diverse country. We're having 64 tribes with 64 languages. Okay, so to address them, they have different culture. Everyone has different culture. So understanding the different cultures, the different beliefs, it will help us to know how to address and develop the communication material. We have to acknowledge and respect diverse beliefs at individual levels, and also there's religion belief about vaccine. Some religion, they don't take vaccine. They believe it is not right for them, and we cannot force them to take it. We can talk to them, try to explain to them how we see it, and then if they accept it, good. If not, you cannot push. So being the understanding and acknowledging, respecting the beliefs of a person, it goes a long way. The other thing that we have to consider is the language barrier. As I mentioned earlier, the 64 tribes, you cannot cover all of them because the material for us to develop even for communication, it requires cost. So we can only cover maybe say 10 or 20 languages. So now it depends on us, which languages are we going to cover to reach those populations. The other thing is literacy level. In most places, especially in the public sector, we have people with illiterate people, or they have limited knowledge about vaccine. How can we approach those people? Which kind of material is best for them to understand and they can relate to? But now we also have over-educated people. You know, those ones, they're the hardest because some people, they don't have medical background, but they're educated in different areas and they have the access to learn and go and read more about vaccine. So when they come to you now, they're going to ask deep questions. Me as a healthcare provider, maybe I did not go that deep even about this specific vaccine. So how am I going to address that person, that over-educated person? As I see now in Juba here, I have like two lawyers that I know, they refuse to give their kids vaccine because they say they don't trust it. The information they read, but I'm very sure they read different websites that have faulty information. So I try to direct them to the WHO website in which they can get better information that will make them feel like, now we are confident in that. So the literacy level is very important to consider in order for us to develop that communication material that can help the patient understand easily and that we can communicate to them. And also cultural responsive communication is important in order for us to improve vaccine acceptance and protect the community from preventable vaccines diseases. Thank you.
Yeah, thank you, Christine. Yeah, for this great answer. Now we are almost approaching to the end. Now let me go to Ms. Joyce Coron. Joyce Coron, kindly, can you tell us what additional support, whether logistical or technical or supervisory, do the Buma Health workers needs most in order to sustain the impact in routine immunizations?
Okay, thank you once more. The most impactful approaches are those that are community-driven, culturally sensitive, and people-centered. So when it's people-centered, it will really have an impact because, you know, when are people going out from their houses, when are they coming back, when are they ready to listen to your messages. So number one is actually using trusted community voices, like the chiefs, the religious leaders, the mothers or the mother-to-mother support groups as advocacy allies. And then two is framing vaccine messages. we have to frame vaccine messages around protection, love, and responsibility instead of having a compliance message. You see, most of our vaccination messages, most of them are compliance. Vaccinate now. So there, I have seen some T-shirts written "Vaccinate now," and you see a health worker with vaccinating. This is compliance. This is really command. And you know, working with the community attitudes, it actually gives them like they are being forced. But if we use love languages or love messages, a message which shows that we love our children, we love vaccination, that is responsibility, then it will really help. Two is Boma health workers, they are leading household dialogues because they have household visits. And one Boma health worker is supposed to be in charge of 40 households. That means these 40 households, you have to know what is happening in those households. And actually, it will also help in storytelling sessions. Some of the family members will actually share their concerns, like said earlier by Dr. Justice about the vaccine hesitancy, fear of the side effects, and all other things. So they become friends to those families, and actually they will now know the benefit of vaccination. Again, this one goes back, like I have visited also several locations. In one of the locations with 100 or 90% literacy level in Eastern Equatoria, I met with the community leaders, and one of them said, you know, there was a measles outbreak sometimes back, and they lost many children because they were refusing vaccination. But now with this vaccination, when they started actually also moving with the vaccinators, with the Boma health workers, people have picked vaccination, and they are no longer actually selling out their cows, and they are not losing their children. That means they have got the benefit of vaccination. And leveraging community health events, or also using communal gatherings. This will promote group outreaches, group awareness through even drama, also sometimes even songs can be composed, a real song which people can dance with. This one will remain in their minds, and also have series of even like let them ask questions. Most of the times we give awareness, but we don't give opportunity to those people who are listening to us. We don't listen to them. And then promoting transparency by explaining the vaccine schedule is very important. The vaccine schedule, most of the people, they don't know. Yes, they come, they said, yes, my child was vaccinated. I was told to come this month to get which vaccine. They say, well, I think the one which is on the left, on the right. So they need also to really be explained to the vaccine schedule, the side effects, and the benefits in relatable terms. Ultimately, the consistency of presence and follow-up by Boma health workers is what builds long-term trust. So once they are consistent and they do follow-ups and their presence in the community, this one will build trust because already they are part of the community, they come from the community, and the community are the ones who are really selected and trusted those Boma health workers. So I think these are a few things which I will say from my end. Thank you.
Thank you very much. Thank you very much. Honorable Director, do you have anything to add on what Madam Joyce said?
Would like to add that the Boma health workers are also present in the urban setup. So there is the block healthcare worker. So every block should have a healthcare worker who will go from house to house, do what the Boma healthcare worker in the village does. Because there is now a lot of urbanization, and also there is the lifestyle is changing. Many of women are now into the workspace, children, they are either brought to the work space or they are left with the caretakers at home. So like when the vaccinators come, they may not find the mothers, and also we might be concentrating on vaccinating the homes when the workplace is where we should be going, or marketplaces. So those are some of the adjustments that need to be done to scale up the vaccination. And then I also want to bring attention to the fact that especially the professional people, vaccination now is viewed as a lowly job only for the vaccinators, and it's not the work of everybody. But ideally, it is the work of starting from the doctor downwards. And in other places, vaccination is only done by certified professionals. So we should also work to change that attitude. And I like a word which Dr. Tongwon said about leadership. Is very important, especially for the pediatrician who are practicing to lead in the immunization of the kids they are seeing, and also to see that some of the private practice could avail vaccination to the kid, because this is an opportunity. When the kid come for other consultation, and if the vaccination status is checked and it is not up to date, then it should also be updated immediately. And I would like to see a situation whereby all the private outlets are able to offer vaccination. And we as a ministry, we are ready to work with them to see modalities of how vaccine, which is offered freely by Gavi, will be available to them to use in the private practice.
Okay, thank you, Dr. Atim. What strategies are currently being implemented or planned to reduce the workload and prevent burnout among vaccinators in the EPI?
You see, we are following the WHO guideline. Usually, the load a vaccinator should do per a day is up to 100 vaccination. So this is why we insist that 2 vaccinators per facility will be enough, because I don't think you will be vaccinating over 200 in a day. So that is one thing. The other thing is, if children are vaccinated at the schedule, then it will reduce the overload that comes from children who have not taken vaccination at the right time of vaccination. Good ratio of people to be vaccinated per vaccinator. So we are continuing to train and also to refresh them so that their skill and their speed of offering the service is improved.
Okay, thank you, Dr. Atim. You have mentioned before that in each facility is supposed to be 2 vaccinator, but you say that most of the places they don't have 2 vaccinator. So now in your answer, you said in each and every facility they have 2 vaccinator, but you are aware that most of them they don't have. So how can you avoid also the burnout of the vaccinator in those facilities that they have one person? to do the work?
Yeah, the implementation is done mostly by our implementing partners. But during the planning phase, we have planned and budgeted for 2 vaccinator facility. Now the implementation is another thing, and this is where we will have to, when we go to do supportive supervision, we will insist that the minimum standard that we have set are met, because sometimes to try to save costs, and you will employ fewer people than is recommended. But during the planning phase, we have a plan and budgeted for 2 vaccinator per health facility. Now it is upon us to sure that what we plan is implemented accordingly.
Yeah, thank you, Dr. Atim. Dr. Jamie Scholl, if you don't have a very burning issue, I will give you the chance after we close all the questions, and then you can add your comment or you can ask a question if it's not a very burning issue. Otherwise, you can write in the chat. Then I will give you chance. If it is a burning issue that can not wait until we finish. So let us, okay, it's okay. So let us continue with our questions. Dr. Christine, can you tell us the role of the pharmacist and the allied health professionals in vaccine advocacy and educations, and how can their full potential be tapped to strengthen immunizations program? Can you tell us the role of the pharmacists and the medical doctors?
Thank you again, Dr. Adu. Hello?
Yes, I'm getting you.
All right. Each person, each healthcare provider, they have a crucial role in order to achieve best vaccination, best health for our patient. Everyone has a role, starting from nurses, doctors, boomer health workers, even the pharmacists. I will focus mostly on pharmacists, but I can go briefly about the healthcare workers. We have the boomer healthcare workers and the nurses. They're working in the front line. They're the frontline educators. They're working in the grassroots, administering vaccination to all the population. And also they're the ones who are building trust through conversation with the parents, with the mothers, through answering questions that they get during their visit to the community. Doctors, they're the leading body. They lead by example. They provide guidance during medical consultation, and they're the one to remove the misconception, because the parents, most of them come to doctors about a specific issue, like something like this: how can I take it and why should I take it? So doctors can clear that misconception about vaccine. And the pharmacists, they're the most accessible providers, because they're everywhere. Everywhere you go, there's a pharmacy. If not a pharmacy, there's a drugstore. So the accessibility of pharmacies, and also they are convenient because they don't ask for any charges to ask for information. The first role of pharmacists is patient counseling and education. Pharmacists play a crucial role in teaching the patient, talking to them about the safety profile of vaccine, so talking to them about the side effect of those vaccines, talking to them about what vaccine is recommended for this child and what not. The second thing, pharmacists are vaccine administration. They do vaccine administration, but only when there's a crisis. For example, during COVID, because there's a shortage of healthcare workers, vaccine also, pharmacists play a role in administering vaccination to the population just to cover the shortage of healthcare workers by that time. The third thing is that they play a great role in immunization program management. And when I say immunization program management, it's a big thing because it involves the supply chain management. pharmacists are the one handling those vaccines. We have the cold chain, we have a specialist in the cold chain department. Those people are there to ensure that vaccine is being handled in a proper way, that vaccine is being stored in the proper temperature, because if that cold chain is broken, the vaccine will be useless. So they work in the supply chain management, they work in vaccine campaigns that are going circulating throughout the country. And also they encourage reporting of adverse drug reaction. In the Ministry of Health now, the Drug and Food Control Authority will have the Pharmacovigilance Department. That department is responsible for reporting the adverse event following immunization. We are not talking about this much, we are not talking enough about this, because if me as a parent and I come and they told me, you take this vaccine is good and so on and so on, the side effect is, for example, diarrhea, fever, and if something extra happen, you come back and report. That will give me confidence in the system that, okay, it's not about just administering, just like dumping and go. I can come back if something severe happened to me. So that will increase the confidence of the public in the healthcare system. So pharmacists encourage reporting of the adverse drug reaction that happen after vaccination. The first thing that pharmacists play also is advocacy and promotion. Pharmacies, they have platforms. For example, the Pharmaceutical Society of South Sudan, they use that platform to advocate not only for vaccine, but for other disease as well. So they advocate for policies that support vaccination as well. They address vaccine hesitancy as well. Vaccine hesitancy is circulating all over and it's something that is common. So pharmacists play a role in addressing and knowing the reason behind this hesitancy. Why are they having this hesitancy? Because they feel free when they're talking to a pharmacist. So by understanding that vaccine hesitation, they can address those hesitation and clear the doubts that they're having in their mind. And by that, they increase acceptance of patients or the parents for vaccination, and they promote a healthier community. Thank you.
Thank you, Dr. Christine, for this very good and nice information. And now finally, Dr. Justin, now the final question is going to you. Dr. Justin, in your professional opinion, what role should CME and professional development play in improving vaccines, confidence, and knowledge among healthcare professionals? Dr. Justin. Dr. Justin.
Hello?
Yes.
Can you hear me? Sorry, I was mute. I was talking while I was mute.
It's okay. It's okay. Now you can continue.
Okay. Regarding this, the role that the continuous medical education plays, to keep doctors up to date with information, you need to really have continuous education for this team that are working in the health professional field. So this CMEs or continuous medical education update clinician, the clinical knowledge in all these health cadres. The impact on the vaccine knowledge and confidence, what does it do? If somebody has the knowledge, it ensures evidence-based and safe vaccine practices. So if these people are given up-to-date information, then they can do the best practices and they can be able to provide vaccines safely. CME deepen knowledge and understanding. And once somebody has good knowledge, it then build on providers' trust in the vaccines, because there are many myths about vaccine. So when you provide facts through the continuous medical education, so these health workers then develop trust in what they are doing, and at the end of the day, be able to do the right thing. It also CME enhances or develop communication and counseling skills in this. And then, so once they have the counseling and better communication skill, then it enhances or addresses vaccine hesitancy effectively. They might be able to communicate effectively to the parent, to their colleagues, and they can handle every difficult question that come across. And so, especially hesitancy. So if you are not able to convince a parent or community with facts, it becomes very difficult. Then this CME arm the health workers with good communication skills. And then it fosters uniformity across cadres. You know, medical professionals, there are level of cadres. There are junior doctors, senior doctors, there are pharmacists and others. So once CME are conducted across the board, it gives uniform information and to build the team, and they become consistent in their doing and consistent in giving their messages. The other point that the CME do and its effect on the vaccination is that CME promote a culture of lifelong learning and accountability. To stay informed, you must have to get new information every day, and so that you can be on board to do many things. So if you are not informed, things can be very, very difficult for you. So it encourages professional accountability that make vaccination a core and make vaccination a core responsibility. Because as I said at the beginning, vaccine and immunization probably in this country has been relegated to people who are not educated, to village health workers and others. But when you continue to give this continuous education, medical education, then the professional take it as a core responsibility, not relegating it to the junior doctors or those below them. Because this is an important exercise. This is an enforcement strategy and a public health intervention that is very, very important even to their work. So they take responsibility and then they become advocates for the vaccine. It also change behavior. And when people change behavior when they're educated, it will translate the knowledge into daily advocacy and practice. So, as I said, in medical school, vaccinology is taught as a subject. But here, it is in CME, we do it practically. And so that practical knowledge then translates into knowledge into the real advocacy and practice work that will help in fostering this endeavor that is very, very important now. And how do we make this vaccine, this CME very attractive to these health workers? We make it accessible to all. We give short module and we make it sure that it is given in a short time, maybe once in the morning meetings, or during a session when you are teaching other things. We make it practical so that we also now these days make sure these health workers, when they come to the hospital, especially even a medical student, we take them for the practice in the vaccination unit that we have here. And so, and that is what we encourage, so that when they go out one day, they become mentors to these low cadres, and that can be very important. And we recommend that it promote interdisciplinary, because it is not one job. For instance, the vaccinators or the people in the cold chain keep the vaccine, the pharmacists, for instance, that is their role in purchasing the vaccine or whatever. We become a unit when we continue to do it. And now, the other thing that we make CMEs attractive and make sure most health workers come, it is linked to certification or incentive. For instance, we give continuous professional development points and recognition. So that make it attractive. And so when they come, they gain this knowledge and they change vaccine direction to the better. Because vaccinology is evolving very fast. On daily basis, there are new information. So these people need to be given current information so that they can affect the practice positively. Thank you.
Yeah, thank you very much. Dr. Justin was our last speaker. So thank you all our panelists for your insightful contributions. We are really grateful. Today we have learned a lot. And I believe each and everyone in this platform have really it's more now we are more educated. We know more informations about the vaccines and how we can improve. So now we're supposed to end by 4. We have 15 minutes to go. So I will open this chance for the floor for questions for our audience. Let us just take 10 minutes. Then the last 5 minutes we can leave it for the closing and then the pictures. So now the floor is open. You can raise your hand or you can put your question in the chat. Also, you can mention also the name of the person you wanted to answer, or you can just put it generally and then anybody can pick an answer. So maybe we can start with Dr. James Chwal. James Chwal, are you still in the call so that we can start with you, then following with Kenyi, and then after that, following with Stephen Yusuf. Okay, if Dr. James is not in the call, maybe we can go to Kenyi.
Yes, good evening.
Good evening.
Yes, my question is in regard to vaccinations and especially specifically for cold chain. We encourage people to get vaccinated, but when you go to the field, some of the far away healthy facilities where they have cold chain either put or they are using cool box are not taken care of. Only become active when people know that there is a campaign, so that you see everything will change. So what could be the best way to support this? Because people who also landed now see that if in the health facilities, the vaccines are not kept well, now you want to immunize my child. So that becomes one of the hindering, obstacle for people go to healthy facility for vaccination. So what could be the best way so that at least these people are well motivated, then they're always on their toe to maintain the cold chain or the fridge as it is required. Thank you very much.
Okay, so I don't know, maybe we can just take 5 questions or 3, and then we give chance for answers. Yes, Stephen?
Yeah, thank you. Thank you so much. Good evening, everyone in the chat. First and foremost, I would like to, the protocol is obviously in place still. I came, I think, halfway through, so I don't know anyone in the board already. But this is quite an interesting, take that we have seen today on the advocacy for vaccines. So I have 2 things. First, I wanted to really thank Dr. Justin Tangon, where he mentioned points of the CMEs and how it can really change the way the health cadres and the teams work together, and how to incentivize it and certain things that do come in place. I have a question earlier. Someone mentioned something about reaching the target population in terms of going to schools and all these target populations that most of the API targets. My question is on concern because of recently. I know some doctor also mentioned on the challenges that are out there. Is on consent. Do the school kids get consented off? Or obviously some parents are online and they do all this, go through all the chats and all the issues that comes with vaccines. What's the consent in terms of that? And my second, yeah, I'm sorry. Am I still audible?
Yes, we are getting you well and clear.
Okay. Okay. Yeah, that's good. Yeah. My second, because of how I know, I don't know if maybe I'm a bit off, but in terms of how parallel most of the API programs are, in terms of adverse reporting of the adverse event, which Doctor mentioned earlier, adverse event following immunization that do occur in terms of the report? Do you get it physical? Do we, with Boomer Health Initiative, do they get it physical? Do they, I just wanted to know that area because I don't know in terms of liaising with centers and other agencies like the DFCA, which of recently has the Pharmacovigilance Center, and they do have certain, aspect of collecting also, immunization. Obviously, we understand that the safety protocols do come after post administrations. So I just wanted that clarity. I hope my questions are a bit clear. If not, then I can try do it as much as possible. Thank you. Thank you so much, the speakers, and thank you, Dr. Justin Tangon.
Okay, thank you very much, Stevens and Kenyi. Dr. James Scholl, are you back? James Scholl, are you back? You can step in and ask questions, or maybe you can add a comment to enrich our meeting, please.
Good afternoon.
Good afternoon. Good afternoon. Good afternoon.
Yeah. I want to say that thank you so much for this advocacy, South Sudan Women Immunization, for your advocacy. One thing that I have concern when I look at when I listen to the colleague who are presenting on the review about immunization, one of the important things that I have seen we need to advocate for is a tetanus vaccine utilization. Because we have seen that most of the children, school children who are in school, have not reached. And now the global initiative said out of 50 countries, is only 49 countries have reached tetanus elimination, in which 10 countries, including South Sudan. How can we do an initiative to make sure that we advocate for TD utilization at health facilities? So that is a question that I want to pose in. Secondly, I have seen that Dr. Atem also talking about the healthcare workers at the health facilities. One thing that we need to improve on is the issue of the leadership and governance, because some of the healthcare workers have left. Because sometimes if they get more motivation from any organization who is supporting the health facilities, then now they will be able also to move and leave their initial work. So this thing also allow even also the facility to have a few staff. Maybe if there are 2 people, now with only one staff will be available. So this is the thing that I want to pose in. How can we improve on this so that the government and leadership will come in, so that most people will be able also to continue with their work. Over from my side.
Thank you, James. Thank you, Dr. James. Yeah, maybe you can answer. If no one else having any other questions, maybe people can respond to our panelists, to Kenyi, Dr. Kenyi, and then Dr. Stephen. So I believe Dr. Stephen questions, the second one is going to Dr. Christine. The adverse drug event. Or anyone from the panelists can just unmute and respond to the 3 questions. And if you need us to repeat the questions, we can ask the doctors to repeat the questions once again. Hello? Dr. Justin, Dr. Christine, Madam Joyce, Honorable Dr. Atim. The floor
Let
is
me try
yours.
to answer
Yes,
the question
please.
for Kenyi, and my other colleagues can add on it. He spoke about the vaccine is not well stored in the rural areas because of the lack of proper storage facilities. Indeed, it happens that this happen, but vaccines are very delicate. So if at some point the cold chain was broken, it wasn't maintained on the proper temperature that is supposed to, it loses its potency. So by that, it will not be effective, even if the person took it 100 times. So it will call for a need for re-immunization. So the person should get the vaccination again with the well vaccine that did not get spoiled. And the good news is the Ministry of Health now, yesterday, they received a donation of cold chain trucks that will indeed improve the cold chain management, because those trucks will maintain the proper temperature for vaccine until they reach to their final destination, or with a proper even increasing the education for healthcare people who are handling those medicine. So continuous professional development is important also. Even if we have all this and we don't know how to use it or how to maintain it, it is very useless. So empowering our healthcare workers on proper handling of this, the cold chain product is very important. Can I proceed with the question for Stephen?
Yes, please.
Okay. Stephen spoke about adverse event following immunization. The pharmacovigilance department was established, I believe, in 2022. It's only 3 years. It's not well known up to now, but efforts have been made. The department distributed the reporting tools on how to report adverse drug reaction in the main hospital, Asaba Hospital, Juba Hospital, and they also went to WOW and Tutorit in the main hospitals, but I believe it did not reach to the Buma Health facilities yet, but efforts are being made to reach those people and to increase awareness about the importance of reporting the adverse drug reaction for all medication, and vaccine is part of them. So thank you.
Thank you, Dr. Christian.
Okay, I pick it from there. The training we give to the vaccinators include a component on AEFI, acute event following immunization, and how to recognize them and to report them. And also, we have a focal person in the department who is responsible for coordinating the AEFI event and even investigating them, and for them to be reported to the pharmacovigilance department. And also, there have been committees formed. In every state, there is an AEFI committee which will respond when there is a reported case of AEFI. And there has been a number of training conducted at the state level to those committees. Plus, there is a national AEFI committee, which is also deals with this. Cold chain maintenance, this is a gap area which we have recognized, and so we designed a short course of 1 month practical training with St. Vincent in Lologo, and we have been training cold chain assistant for 1 month, batches of 30, and then up to now we have trained up to 150, and we have covered all the counties. Every county at least has one of those cold chain assistants. And if the resources become available, we wanted to continue to train more cold chain assistants, such that at least most of the cold chain will have somebody knowledgeable to look after them to ensure that the vaccines are kept well. Also, you have seen the trucks that we have received. The truck are twofold. One, because when we transport the vaccine, we transport it by air, and it is very expensive, and it adds to the cost of vaccination. So now we want to move away from the transporting the vaccine by air to transporting it by trucks as roads become available. So for this one, we need refrigerated trucks that will take the vaccine from point A to point B in optimum condition. About the consent of school children vaccination, most of our vaccination happen to the under 5, usually before school age, but even in like in Juba, the schools are the ones usually to seek the consent of the parents for the vaccination. We don't go to schools for vaccination, but if it happens, usually the school will send a consent form to the parent to come to the school to give consent to their children to be vaccinated. But usually we want to target the children for vaccination at home when the parents and those guardians are available, and they will be the one to give consent to it. Yes, for the tetanus, there is an elimination program happening, and it is only because of the challenges of vaccination in our kind of setup that is making it difficult. But we are trying our best to do the tetanus elimination like the rest of the world, but we are lagging behind because of, as you have heard earlier, we have a human resource issue, we have cold chain issues, we have knowledge issue, communities that are not well informed, and so on. So those are the things that are keeping us not joining the rest of the world in the tetanus elimination. Thank you.
Yeah, thank you, Honorable Dr. Atim. The time is going, it's already 2 minutes to 4. And I believe we're supposed to close by 4, so maybe we can just take 10 minutes. Then we close for 10, and we close our session. So now I'm going to give closing remark to our speakers. Each and everyone, I will give you just 1 minute. Please just use the 1 minute or less. Then we can proceed to the next step. Let us start with Honorable Dr. Atim, following with Dr. Justin, then following with Madam Joyce, then we will close with Dr. Christine.
In my closing remark, I want to take the challenge from the pharmacists. The accessibility, of course, they have the knowledge to do vaccination and so on. So I am going to offer to them to get the immunization and practice training, which is a 5-day training, and then they be certified to then be able to provide vaccination in their outlets. This will, of course, be a good addition to the immunization system. Also, I want to appeal to the pediatricians, especially in Juba here. Why can't we meet and see how we can avail the vaccination in your practice such that you can have access to the vaccine? Because this is a public vaccine, it is provided free, and all that we need is to find ways for it to be delivered to you and the children that are under your care. So those are my closing remarks. I'm throwing it back to you to engage us and see how we can take it further. Thank you.
Thank you very much. Dr. Justin.
Thank you very much for this opportunity to share the little knowledge we know about vaccines and vaccinology in general. My last word will be to all who are listening, and I want you to take this message out. Vaccines and vaccination is a game changer. Once we promote it and we effectively vaccinate our children effectively to 90%, mortality will automatically drop, morbidity will reduce, and we'll have safer population and healthier population of children. So it is an important public health intervention that need all of us to promote it. This, if it is coupled with clean water and sanitation, and then improved nutrition, basically our hospital will be empty, because then the children will be healthy and they will never get to overburden the health system. It is an important investment, and please let us put our energy to promote immunization or vaccination in general. Thank you very much.
Thank you, Dr. Justin. Madam Joyce.
Thank you all for this opportunity, and I really feel a pleasure that I participated in this first meeting for Sswim. Actually, in the beginning, I was wondering what is a Sswim, but later on, I knew from your briefing, and I have only the message is that engagement with continuous engagement and coordination of partners and stakeholders, this will really link us to the improvement of immunization coverage, because immunization is just not a standalone, but there are many contributors and there are a lot of challenges, but each and every stakeholder or our partner have a role to contribute to improve immunization. Thank you.
Madam Joyce. Dr. Christine.
I would like to appreciate the South Sudan Women in Medicine leadership for arranging this amazing program and giving us the chance, the healthcare workers, to come together and discuss these topics. My message that I want the audience to go with is the importance of investing in healthcare workers as vaccine advocates. By strengthening their ability to educate and protect communities, we create a healthier community for all. Thank you.
Thank you very much. Thank you all for being part of these powerful and insightful discussions today. As we draw this webinar to close, I would like to reflect on a few key takeaways from this meeting. First, we were reminded of the vital role of every health workers, from doctors, pharmacists, to community vaccinators, boomer health workers, all plays in building trust and driving demand for immunizations, empowering and equipping them through continuous medical educations. It's not just a priority, it is a necessity if we are to keep pace with new vaccines and evolving community needs. We also heard clearly about the gaps that is still existing, especially in human resources and logistic, and the importance of mobilizing resources to ensure no child is left behind due to the lack of the supplies or the trained personnel. Most importantly today, conversations highlighted the power of collaborations. When we work together, government, health workers, partners, and communities, we can transform South Sudan immunizations landscape and build a stronger, more resilient health system. On behalf of the organizing team, Women in Medicine, thank you once again to our panelists attendees and partners for your time, your insight, and your commitment to championing health for all. Let us continue to stand together in equipping and empowering our frontline health workforce. Thank you very much. Let us go back to Dr. Sarah.
Thank you very much, Dr. Adut, for moderating this webinar. Thank you very much, Dr. Tim, Dr. Justin, Dr. Christine, and Ms. Joyce. Thank you very much, all our audiences. Thank you all for this wonderful participation. It was our pleasure to have all of you with us here today. Actually, your insights, your expertise has provided valuable perspective that will guide our future effort. That was really wonderful. Thank you all very much. So this webinar marks the end of our webinar series. And before the end of this month, we will be crafting a report about the webinar series. The report will be shared with all our speakers, moderators, and all our audiences who registered to attend the webinars with their email addresses. We will be able to get the email addresses and we will share with them the report. So all of you should be expecting a report from us before the end of this month. So the last session of this webinar, I know we are late by 11 minutes, but we will have to finish it all. So the last session is the photo shot. I will kindly ask all of you to switch on your cameras and we'll be able to take a screenshot of all of us. That will be taken as a group photo. So I kindly ask all of you to switch on your cameras. I don't see all of you here.
You say cheese when we are ready.
I am the photographer, so please just smile, put on your best smile. 1, 2, 3. 1, 2, 3. 1, 2, 3. We're done.
Okay, thank you very much, Dr. Emily, for being our today's photographer.
Thank you.
By this, we call it a day. Thank you once again for this wonderful participations, and hopefully we are going to engage again in other activities. Okay, thank you very much. Have a lovely evening.
And you too. Happy weekend.
Thank you, likewise.
Thank you. Bye-bye.
All right, bye-bye. It's nice meeting you all.
Thank you.
Bye.
Where did you go? Okay. Is the meeting over? Yeah. It disappeared. It is bringing us. I hope you're not talking. Unless it was a computer.
Okay, let me check. Live stream. It might have
It didn't.
a-
It didn't. You see us?
Okay.
Yes, you see us there. Mm-hmm.
No problem. The tab is open. It is still live streaming. Was your microphone on?
It did disappear the channel was people.
And even your camera is on.
Mm-hmm.
It's a browser.
Mm-hmm.
Because it has just ended. It usually shows that.